Hello everyone. Again, I welcome you all to my lecture class, and in my today's lecture class, I'm going to talk about a common and specific autonomic dysfunction syndrome, that is POTS or postural orthostatic tachycardia syndrome. In my previous lectures, I have already talked about the anatomy and physiology of autonomic nervous system. I have talked about various autonomic function tests, and I have also talked about the management of common autonomic dysfunctions. So now let's see what is POTS or postural orthostatic tachycardia syndrome. In POTS, there will be orthostatic intolerance and there will be tachycardia of more than 120 beats per minute, or there will be increase in heart rate by more than 30 beats per minute from the baseline, but there will be no orthostatic hypotension, that is without orthostatic hypotension. It is commoner in female in the age group of 15 to 50 years. Clinical features of postural orthostatic tachycardia syndrome are like lightheadedness, there may be nausea or vomiting, patient may have pre-syncope, and there will be orthostatic intolerance, and the symptoms usually improves with lying down. The mechanism of orthostatic tachycardia syndrome may be diverse. There may be distal denervation or cardiac deconditioning. There may be impaired baroreceptor reflex in the brain. There may be hypovolemia or impaired sympathetic function. Now, how we treat a case of POTS? The treatment may be non-pharmacological or pharmacological. In the non-pharmacological management, we can educate the patient about POTS and the stressors of POTS. Okay, we can also give them postural training. There should be gradual transitioning between posture, not like sudden change of posture. The patient should not suddenly stand up from lying down, or the patient should not suddenly stand up from sitting position. There should be high salt intake and there should be high liquid intake to maintain a urine output of around 1.5 to 2.5 liters a day. In the pharmacological management, there are a few drugs which can be used like midodrine, pyridostigmine and fludrocortisone. Midodrine is an alpha-1 agonist. It can be used at a dose of 5 to 10 milligram 3 times a day. Pyridostigmine is an enhancer of ganglionic transmission which can also be used, and fludrocortisone is a mineralocorticoid which can be used at a dose of 0.1 to 0.3 milligram per day. Midodrine and fludrocortisone may cause supine hypertension, but which is not there with pyridostigmine. Pyridostigmine does not cause supine hypertension. This is because pyridostigmine enhances the ganglionic transmission only and mostly on standing, not on supine position. So this is in short about postural orthostatic tachycardia syndrome or POTS. Thank you.